Now, this is a topic that perhaps people don't necessarily talk about enough, and we're going to encourage you to think about it a little bit now, because a group of medical professionals in the county are working together with care homes, hospitals, hospices to change the way people make choices about the care they receive and what they want to happen to them in terms of treatment in the future. Joining me now is the chair of the End of Life Group, Derek Willis, Speciality Doctor in Advanced Care Planning, Julia Head, and the Vice Chair of Telford Patient First, Dave Morgan. Good evening, all of you.
Hi, Mark. Hello.
Hello.
Good evening.
Good evening. Derek, just explain to me what you're doing and why.
So what we're trying to do is to get people to have conversations with the people that they love and care about, just to say, look, in the future, if I reach the point where I'm unable to tell you what my preferences are about my treatment, where I'd want to go, and treatments that I might not want to need, here are the kind of things and here are the kind of decisions, if I could tell you, that I would want. So it takes the pressure off a relative of being the one who has to often make decisions that they don't really know whether they're what their loved one will want to do. Because let's face it, it's a conversation that as people, and I would argue particularly as British people, we are really awful at having. And I think particularly Dave's story kind of illustrates that really well, how not just the conversation, but the way that we document that is important, so healthcare professionals can know and act on what people have said in the past when they've been able to communicate.
Dave, go on. Tell me about what you do and where you come at this from.
Well, Mark, I'm vice chair of Telford Patient First Group. It's a voluntary group, and various people from practices, patient groups sit on that, and from other voluntary organisations. So there's a lot of shared experience. But personally, my experience of trying to discuss the subject of where do you want to go with your life to close relatives, parents, and and in friends, to be honest, is that you feel stressed as a person trying to raise this. You know that the person concerned feels bad and feels guilty that they're putting under pressure. There's a lot of emotions, and from my point of view, it feels like it's taboo to speak about to start with, and when you do, it's a stigma. And which one of you, close family, which one of you brothers and sisters are going to bring this idea, float this subject up to your parents? And when you do, who do you speak to? And if you do speak to someone, is it the right person? And if it is the right person, does that information follow your loved one through the system? And more often than not, within the old system, it doesn't, and it causes increased frustration, and it gets so repetitive. It not only takes a lot more of your emotions, it also uses more time up from the medical staff in various departments, maybe throughout the hospitals in different wards and in different places. So it's not very practical. What we're looking for is something that's practical so we can control our futures. Whereas Derek said that it's, sort of, and you mentioned end of life, it's not about just planning that you control your future for end of life. It's about analysing maybe a lot younger. What's wrong with talking about it in the workplace or amongst your friends and colleagues when you're younger? It doesn't happen. We're British. Let's talk about it.
Julia, I just wonder whether this is, and I think I'm guilty of viewing health services as like this. I go to the doctor, they tell me what's wrong with me, they then tell me what they're going to do to put it right, and I don't kind of assume I have much choice in it. What sort of choices are we talking about here?
Yeah, I think that's a really, really good point. And I think the whole point of what we're talking about, which is advanced care planning, is giving people like you, like your parents, like your loved ones, a voice about how you want to be treated now, but also how you want to be treated in the future. So the whole point of advanced care planning is it's really holistic. And what I mean by that is that you talk about what's working well at the moment, what problems you're having at the moment, whether you've got health issues or social care issues. You then talk about perhaps some of the medical things that you might need in the future, and any particular sort of feelings or worries that you've got and things that you're frightened of happening to you. And some people have really, really strong feelings about what they do and don't want, and other people don't. Other people need time to think about it. They need to hear the options, and it's about having a really informed choice as well. So advanced care planning is a whole conversation, and it doesn't just take place on one occasion. It takes place over many conversations involving as many people as possible who know you well, but with a healthcare professional as well who can support you, and most importantly, write it down. Because as Dave said, when you're really unwell and you're in hospital and you're in A&E, particularly at the moment when you're not allowed anyone to come in with you, if you've got it written down, and a little bit about who you are as well, your own personal story, and what are the things that you value in life, as well as the medical stuff, it really, really helps doctors and nurses who don't necessarily know you make the right choices for you if you can't tell them at the time.
Derek, is this something you need to keep up to date? Because my preferences for how I would want to be treated now as a fairly healthy young adult might be different to my preferences in, 50 years' time. Is it something, a bit like a will, I guess, that you need to keep up to date?
Yeah, you're right, Mark. It's an ongoing conversation, isn't it? So what a kind of life looks like to me now might actually be really different when I get there. It's a bit of a stupid example, but when I was a teenager, thinking about being a 40-year-old bloke was just the worst thing you could possibly think. But now that I'm 40, believe it or not, kind of another decade on top, actually I think my quality of life is probably better than it was when I was a teenager. So you're right. Sometimes how things look at a particular time might be different when we get there. So it's not like we're saying to people, this is written down and you absolutely have to follow it. So what it is trying to do is stop relatives feeling that they're responsible for something that they may not know, but also empowering kind of particular paramedic groups who turn up where they're being told by someone they wouldn't want to go into hospital but have no evidence for it. So one of the worst things that I often come across is when I look after patients who I know that they want to stay at home, who've ended up going into hospital because we just haven't firmed it up enough to give the relative the power to say, look, it's written down on the piece of paper, and the ambulance crew or the doctor or the nurse enough kind of reassurance that actually this is true and this is what that patient would have wanted. So you're right, it is something that we write, but we would need to keep revisiting it because sometimes things look different when you're actually in that circumstance.
This feels like a kind of an advisory document, Dave, that kind of just sets out some preferences. Am I getting this right? That kind of, if possible, allow me to stay at home. If possible, don't treat me in a certain way. Am I kind of understanding?
Well, at the moment, yes, it is, and it will be up to the individual, and maybe the practitioners and who can advise patients if they were, during a normal visit to the practice, that is there an issue, or talk to family members, is there an issue, or it could be family members that talk to the practitioner saying they're concerned, So yes, it's advisory, but the other thing about it may change. It needs to be fluid for that period of time when you start discussing it from then on, because science changes, technology changes. The last year has seen how great technology can be and science can be to pull things together. That can happen with your illness and with your needs of supporting that illness. Things can change, and it may be by having these the big conversations, but the more intrusive, sensitive conversations, that people have then identified what you actually need, and some of those needs can then be met at home, instead of going into a care home or something similar where you have closer attention. My mother had made a decision to go to care home. She felt really guilty that she felt that she putting pressure on the family, and by a process, she and she went in through the hospital and into another ward and going through the system. She changed her mind. She decided, even at the age of 90, I'm too young, and she's back. She's at home now, but she's supported by 2 carers and every other day a district nurse. She's still got the illnesses, but she's happier with herself. But that was a decision made at the last minute, and it caused quite a bit of upset for herself and for us as a family. But she's happy. But that calmness can be introduced a lot earlier for a lot of people by this system.
Julia,
Mark, you used a word I really like, which is the word preferences.
Yeah.
One of the things that we don't want to happen is that we're making family members feel guilty if some of what a relative wants to do can't be respected.
Yeah.
And when you use the word of preferences, you can say, well, I'd rather stay at home, but if circumstances make it that I can't stay at home, the next place that would be okay would hospital. And then actually, if hospital's not appropriate, care home's okay. Whereas I come across some people who feel so guilty because they say, Mum's wish was to stay at home. It got too complicated and we couldn't do it. Was this idea of preferences of how does it look like? Where would be the first place? What would the next thing be? Empowers families to actually feel like, you know what, if Mum was here, she'd say, look, it's all right. I know you've tried. And I know that sometimes when people are bereaved, if they don't feel they've respected what their relative want, it just makes it much more complicated.
It gives you an approved plan B and C, I guess, which is quite reassuring.
So it isn't under all circumstances, I want this full stop. It's look, if it just doesn't end up being practical, what else would be okay, knowing that your first preference would be X.
Julia, I just wonder what are the concerns people raise when having these conversations? Is it about kind of being worried that by in some way enabling people to do so that they won't get the treatment they need? Are people worried that, pressures on the health service will kind of allow them to be encouraged out of the door of the hospital, if that makes sense?
Yeah, I think there's quite a lot of concern, particularly at the moment, and we've heard an awful lot, haven't we, particularly during COVID, about the really difficult situation care home residents have been in. And it also gets a little bit muddled up, I think, with resuscitation decisions. And actually, this is very, very much about what we can do and when to go to hospital, not trying to stop people from going to hospital. This is absolutely about acknowledging somebody's health needs. And I think what Dave and Derek have talked about particularly is sort of end of life, but actually I've been doing an awful lot of advanced care planning in care homes during the COVID crisis with people who are nowhere near the end of life, but they're in care homes for various reasons. And really, it's just a chance to really say, how are you? How are you doing? What are the things that you're struggling with? And, have you thought a little bit about if those things get worse, where do you want to be treated? But also being really, really honest with them about what doctors would offer. And I think it's fair to say that if you're sort of approaching your 100th birthday, most doctors would be very, very reluctant to say, look, we would offer you absolutely everything because we wouldn't want to do more harm than good. But that doesn't necessarily mean that you wouldn't go to hospital. It doesn't necessarily mean that you wouldn't have lots of other active treatments, be on the ward, have IV antibiotics, or not. And if that person says, please, I've had a lot of conversations with people in the last 6 months who said, I'm really very tired. I'm very happy to stay here. Yes, please, I'd really like some antibiotics if I get a chest infection or a urine infection or something. But actually, I really don't want to go to hospital at the moment. And sometimes, though, I find myself challenging that because I will look at them and think, do you know what? You're really, really good. And what we have to be really careful about here is not being ageist. So when we talk to people in care homes, we ignore their age completely. And we look very much at what they're able to do and their what we call a frailty score. So if somebody can be 105 and walking around and really able and still really independent, but needs a little bit of help with, showering and cooking, or you could be, in bed and needing a huge amount of care. And so this is about quality of life, and it's about your level of expectation, what you want, and where you want it. And it's about preferences, but it's also having a really honest conversation with your doctor and somebody who you trust and your family around you to support you, to think about what it really means to be in hospital, what those treatments might be like, and the risks and the benefits of them.
So how do we
And,
do this?
And I guess one of the things I'd add as well is that a lot of patients are relieved to actually be having the conversation.
Yeah.
They're actually waiting for us to bring it up. But it almost feels like, well, I can't talk to a doctor about not wanting things because I'm letting the doctor down. And when actually the patient goes, well, I really don't want to go to hospital. And us bringing it up, you can almost hear the sigh of relief of someone's actually having the conversation I wanted. And I guess if there's one thing that we're really keen about is that people feel empowered to actually say, I want to have the conversation. So they're not waiting to be asked. They're actually saying, look, this is a good time for us to actually start writing it down and maybe have a chat with a healthcare professional you know quite well.
How do you do it? Is there a kind of an official route to go down to kind of compile these sort of recorded thoughts?
I totally would echo what Derek has said there. And in terms of, the responses we had when we were in the care homes over COVID was, thank you so much. I really, really was worrying about this, and I'm really relieved. So we'd talk to the residents, we'd talk to the carers, and we'd pick up the phone and talk to relatives as well. Obviously, we'd much prefer to do it face to face, but that just wasn't possible in because of lockdown. But by far, the huge majority of people were just really grateful that we had asked the questions and they were able to write something down.
And they can feel a part of it, can't they? They can feel a part of their own treatment, and like they're controlling their own destiny in some way. It's quite damaging to feel like you're on a treadmill and it's happening to you rather than with you.
That's exactly right. And I think a lot of people sort of just said, I hadn't realised that I was allowed to tell you. It's absolutely you're allowed to tell us. This is your voice, and we really, really want to respect you so that you have dignity wherever you are and you get the treatments that you're entitled to, but you also don't get things done to you that you really don't want.
How do we do it then? Is this a case of speaking to a doctor? Do you just kind of write it down in a more informal way? What are you looking for?
So what we're trying to do is to get some form of document that's recognised across the healthcare economy. So in a quick situation where an ambulance driver, whoever is turning up in an emergency, there's an identifiable bit of documentation that, oh yes, that's the advanced care plan. What the advanced care plan can't be is it can't be a tick box yes or no exercise. What it does to have is a description of, I don't know, for example, if I end up with a chest infection, I would want oral antibiotics, but I wouldn't want intravenous when going into hospital. So it's a bit more nuanced than sitting down, just going through the, yes, no, what's your name, where are you from? So we're actually recording things, but then some way of just having a bit of a summary at the end so that you can actually see what it is, rather than going through loads and loads of pages with it. So I guess what I'm trying to say is that we don't want this to feel like it's a production line where we're just kind of not having any discussion or any ability of the patient or person to write down what they think. But it's got to be practical, that everybody recognises that this is the advanced care plan. Because you could write it down on a bus ticket and still say that this is what I want. But then in that emergency situation, you need to know that document's going to be recognised by everybody within the healthcare economy.
But we can currently have conversations with our doctors and have those recorded, Julia.
Yes, absolutely. I think it's fair to say that at the moment our GP colleagues are really under it and doing an amazing job at the moment doing vaccinations. So I would probably say that for now, over the next few weeks, perhaps not, ringing your GP and saying, please can I have a discussion? But actually many people, particularly who've got complicated or complex health needs, have got fantastic specialist nurses, they've got great carers. And these conversations, as well as their family, of course, and these conversations can start to be put together with those people, particularly with a specialist nurse or a nursing colleague or carer, who can then trigger and say, look, we've had some ideas, we've had some chats over, many weeks, often, but now we need to kind of formalise it a little bit. And that would be absolutely when you'd either want to perhaps pull in your GP or somebody from the hospice like Derek or myself in one of the sort of more specialist advanced care planning teams, but it doesn't have to be specialist. It could really be any healthcare professional. And one of the things that we've been really trying to do with the care homes is to deliver some training for them as well, because they know the residents so well. And I mean, I'm obviously concentrating on care homes at the moment because that's been my job for the last sort of year, but this could be for anybody. But anybody who knows that person well is absolutely qualified to write these things down. Yes, there probably needs to be a little bit of a medical stuff in it at some point for particular symptom control or those sort of feelings of care, if you like. Do you want to go to hospital or not? And if you go, what's going to happen to you? But actually, a lot of it can be done sort of in advance and with people who just know you really well. And then at some point, you need to contact a healthcare professional that you trust and that you feel has got some time to give you, which of course time's precious, but to contact somebody who you trust, who can then take that forward for you.
Dave, it must be a big relief as a family member to be able to take into account what your loved one thinks and feels and know you're on solid ground with that.
Well, yeah, absolutely. I just think it gives me confidence, and I'm fairly excited about this because it gives you or anybody, it gives me that framework to work with. I mean, I don't know whether it's as easy to contact your surgery, your primary care networks, your local practice, to have these conversations previously. We've found it difficult to identify the people, but there are things in place. But with this sitting to be not just to be launched, to be used by the primary care networks, with all the organisations within the system, what it does is give me safeguards because those conversations can be forever going. You can make adjustments according to need. It hasn't got to be just because the person's elderly. You could have physical and mental health problems earlier in your life, which you need support for, and it can be managed. It can be improved by having this in place, and so it gives you that quality and hopefully the ability to manage your life that much better. And I just think it gives you, it makes you feel more comfortable as a family member.
When we're allowed to do it properly, I'd love to have a bit of a round table about this sort of stuff because I think it's massively important and we don't certainly talk about it enough. So it'd be great if you all keep in touch and let me know how it's progressing. And before I go, how are you all doing working in healthcare? I feel it would be remiss of me not to ask.
I guess first of all, I'd like to say thank you to Radio Shropshire. You guys have kept us all going, and you keeping a kind of a mixture of informing us what's going on, but also giving us stuff to smile. You've helped us, so thank you, Radio Shropshire, and thank you, local radio. I am just bowled over with how amazing my colleagues are. And yes, it's possible to get overwhelmed by being in the middle of a pandemic. Who'd want to live through that?
Yeah.
But to kind of think that we live in a place where people aren't altruistic and don't go into healthcare because they care about people. The sheer acts of kindness I've seen from healthcare people, that the barriers between various places are going and everybody getting stuck in, particularly in Shropshire, to try and do the right thing and get us through the pandemic. I'm tired, I'm exhausted, but I'm really cheered up by how amazing our healthcare system and our care homes and all our carers are. And it makes me really proud of Shropshire.
Well, it's great to hear that. And look, all of you, thanks a lot for giving up some of your evening. I know you're all busy and thank you very much for coming on and talking about something so important. Appreciate it.
Thank you.
Cheers,